This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2014, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. As this week is Patient Safety Awareness Week, I welcome you to today's presentation, Patient Safety and the Hazards of Suctioning. Upon completion of this AARC webcast, participants will be able to choose the contributing factors that are mechanisms of lung inflammation and damage in mechanical ventilation, explain strategies to avoid hospital-acquired infection, understand how to prevent inadvertent oversuctioning, tissue trauma, and traumatic atelectasis, identify how current evidence-based guidelines address patient safety issues relative to suctioning, and identify actions you can take to enhance patient safety. I am pleased to welcome Mr. Bill Lamb. Mr. Lamb is a respiratory therapist, Certified Pulmonary Function Technologist, and AARC Fellow. He is the National Clinical Manager for Ohio Medical Corporation and serves on the Respiratory Care Advisory Committees at the University of Missouri in Columbia, St. Louis Community College at Forest Park, and Southwest Illinois College in Belleville. Mr. Lamb is also a Director-at-Large for the AARC Board of Directors and served as the Speaker of the House in the AARC House of Delegates in 2011. I do not have conflicts of interest related to this presentation. Mr. Lamb discloses that he is an employee of Ohio Medical Corporation in Gurnee, Illinois. Any use of images or brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis. Bill, welcome to the program.
Thank you, Dr. Strickland, and good day, everyone. I'm going to talk about patient safety today relative to suctioning. The first issue we're going to discuss is healthcare reform. We all know that not that patient safety wasn't important before, but it's an absolute necessity now, because with the new structure with healthcare reform with an accountable care organization, we're all assessed based on our outcomes. So we're rewarded for good outcomes and we're penalized for bad outcomes. So every team member can make a difference in how the patient flows through our hospitals. Is there room for improvement in patient safety? These are data that my good friend Patrick Dunn tells me they're understated based on the National Patient Safety Conference he recently attended in Los Angeles. And I would emphasize these are reported hospital errors. But we know that hospital errors are very underreported. We all know that things happen within our institutions where we say, oh, that could have been really bad, or no harm, no foul, so we're not going to write an incident report, etc. But clearly there's a lot of room for improvement in how we manage patients within our institutions. We all know that we have lung protective strategies. We've got the ARDSNet as a benchmark that tells us if we use small tidal volumes that the outcomes are much better. So that's a lung protective strategy. It's a patient safety issue. And the biggest new lung protective strategy that we're all dealing with is what I call endotracheal tube-associated pneumonia or ventilator-associated events. And what do we do to help mitigate these? We put the patient's head up. We do oral care by swabbing out the patient's mouth with antiseptic. We do subglottic secretion removal, and we'll talk more about that, to evacuate secretions above the endotracheal tube cuff. We have to pay attention to cuff pressure regulation in terms of how much air is in the cuff and what kind of secretions might be seeping around the cuff into the lower airway, thus causing infections and inflammation. And then there's biofilm in the endotracheal tube. We all know that biofilm begins to be significant in the endotracheal tube after 48 hours. We know that VAP is now recognized as one of the most common and frequently fatal type of hospital-acquired pneumonia. Published data show that there's more deaths due to ventilator-associated pneumonia than with urinary tract infections from central lines or even surgical site infections. There are new terminology to help reporting of ventilator-associated events. We have ventilator-associated conditions, we have infection-related ventilator-associated conditions, and we have possible or probable VAP. You all probably know, if you're within a healthcare system, that one hospital's, quote, VAP rate was significantly different than the others. And the question is, how can that be? And it's based on how we report it. What one hospital considered a ventilator-associated pneumonia, what another hospital did not. So the new ventilator-associated events categorizations are intended to help clarify these things and to help more accurate reporting. All of these issues resolve around the endotracheal tube, and specifically down in the subglottic area. We know that we have biofilm that forms within the endotracheal tube. We know that the endotracheal tube cuff is hard to maintain pressure-wise, and we know that secretions pool on top of the endotracheal cuff and find their way into the lower airway. So cuff pressure regulation. There's a high-end solution to this problem. There's a low-end solution to this problem. A high-end solution to the problem is some ventilator manufacturers are now incorporating cuff pressure maintenance within the microprocessing systems of the mechanical ventilator. There's also a standalone version that actually just plugs into an air or an oxygen flow meter that has an inherent manometer and actually will maintain a constant cuff pressure on the endotracheal tube cuff. In terms of biofilm, there's several innovations that I think are going to affect how biofilm is removed from the endotracheal tube. There's an Omniotech product called a Rescue Cath. There's other examples, are mucus shaver or EndoClear, to where you actually place the cursor of the device at the length of the endotracheal tube, and when you slide it into the endotracheal tube, it's at the tip of the tube, and then in this case, the Rescue Cath, there's a Teflon balloon that actually inflates to help scrape out the debris and the biofilm. Data has shown that this will return a tube to 98% patency. And this is just an example of a mucus plug that was taken out of a patient using the Rescue Cath as a viable alternative versus reintubation. So I think what we may see in the future is these types of technologies will be integrated into a suction catheter to where maybe once or twice per shift the respiratory therapist or nurse goes down and strips out the biofilm from the endotracheal tube. So for the remainder of the talk, we're going to talk about an additional lung protective strategy and safe suctioning. And we're going to focus on airway suctioning and subglottic secretion removal. AARC released new clinical practice guidelines regarding endotracheal suctioning in the June 2010 issue of Respiratory Care. The highlights of that guideline are suction pressures, adults less than 150 millimeters of mercury, neonatal and pediatric patients less than 80 to 100 millimeters of mercury. Now this doesn't say that if you're using 120 as your standard operating procedure that you should increase the pressure to 150. In fact, all things suctioning, you should always use the minimal amount of pressure that's appropriate to achieve the goal that you're trying to achieve. The next recommendation was that deep suctioning may cause significant tracheal mucosal damage and is no longer recommended. So the notion that where we go down until we feel resistance and back up a couple of centimeters is now no longer recommended due to tissue damage. Anyone who's ever assisted with a bronchoscopy, that's exactly what you see, as you see little hickeys at the carina due to endotracheal tube suctioning. Do not disconnect the patient from the ventilator. It's pretty widespread now use of inline endotracheal closed systems for suctioning. And then the last thing is occlude the tubing while setting the maximum suction pressure. This is something that most people were either never taught or they don't know. or they know it, but it's a human behavioral element, they forget to do it. And that's the notion that you should actually occlude the tubing while setting the maximum pressure. So rather than setting the suction regulator like a flow meter, you have to occlude it to set it. So again, occlude the tubing while setting the suction pressure, and then also checking the suction pressure before every suction event. So when you go to do the endotracheal tube procedure, you should occlude the tubing to make sure the pressure is maintained where you suspect it to be. Oftentimes upon clinical audits, we see this pressure being way higher than wanted, and it's because someone had used the same catheter to suction out the nose or the mouth, and then they didn't return the pressure back to normal before they do a suction event. So set that pressure to 150 or less. Again, the minimal amount of pressure is appropriate to achieve your goal. And then set the suction pressure to 80 to 100 for neonates and peds. So what do we mean by shallow suctioning? Here's an endotracheal tube to where the markings on the top of the endotracheal tube are on the tube, and then what you're doing is you're looking through the endotracheal tube at the suction catheter, and you'll see those same markings. So to shallow suction, one needs only to line up those two markings. In this case, the marking 28 was lined up with the catheter and with the endotracheal tube, so that you can be sure you're suctioning at the end of the endotracheal tube. And if you don't do that and you deep suction, you could cause injuries such as you see in this picture. I want to introduce you to a term, inadvertent oversuctioning. Inadvertent oversuctioning is a result of improperly set vacuum regulators. And it commonly results from, again, lack of understanding of how to properly set the vacuum regulator, and it can expose a patient up to 15 times higher pressure than recommended. For nasogastric or endotracheal suction procedures or for subglottic secretion removals. This results in tissue trauma, infection, and traumatic atelectasis. When we're doing endotracheal tube suctioning, we want to preserve FAARC, and so we want nice open lungs as opposed to closed lungs. Why do these vacuum systems have to be so powerful? One of them would barely fit in a conference room at your hospital, and they have to provide enough force to provide vacuum throughout the entire campus. So, a patient in the intensive care unit might be using 4 or 5 vacuum regulators, depending on how many chest tubes they have, if they're doing subglottic secretion removal, endotracheal tube suction, nasogastric suction, etc. And then you have your operating room suite, who's the only area of the hospital that it's okay to use wide open suctioning continuously, and that's because they're irrigating surgical fields. So you've got to have enough power to supply vacuum through the entire campus. This is just representative of how much power you have. This is your typical wall system, which shows a pressure of 17 inches of mercury, which translates to over 600 millimeters of mercury, which is the working pressures that we use in the wall. And on the right-hand side, you have a vacuum regulator that was set like a flow meter without occluding, and you have a 2-liter soda bottle that it's attached to, and within about 3 seconds, it will actually implode that soda bottle. So that's how much power you actually have behind that wall in those vacuum regulators. So one must be real cautious of how they apply that to a patient. Again, the guidelines state that the negative pressure should be checked by occluding the end of the tubing before attaching it to the suction catheter and prior to each suctioning event. This is a standard vacuum regulator, and this is the vacuum pressure being set without occluding it. Once it's occluded, simulating what happens down in the airway, you can see the pressure is well above 270 millimeters of mercury. And again, this is what actually happens down in the lung. When you suction, especially when you deep suction, you're going to occlude all of those ports, and you're going to do basically a tissue biopsy because you're using way too much pressure. The correct way to set a vacuum regulator is to occlude the end of the tubing and while it's occluded, set the appropriate vacuum pressure. So we've got 130 millimeters of mercury here. And then when you do the same exercise and occluding the catheter, you still have 130, stacked it to 132. So it's very important that you occlude to set the tubing when you set the vacuum regulator. In fact, I like to actually occlude the tubing back up at the vacuum regulator just in case there's a leak in the suction canister system or the tubing. And if that's corrected later, it could result in inadvertent oversuctioning by too much pressure. So, again, that's a preference thing. Here's a study that was published in the Journal of Infection Control in July of 2010 by Persley and his group in Springfield, Missouri. And what he did is he looked at pre-suction and expiratory lung volume, or FRC, and then he looked at that by setting the vacuum regulator with occluding it to setting it, which was actual pressure of 120 millimeters of mercury, which caused a 10% reduction in functional residual capacity. And then he looked at setting the vacuum regulator at 120 millimeters of mercury without occluding it, and it actually resulted in a pressure of 220 millimeters of mercury, and it resulted in a 71% reduction in functional residual capacity. This is just a graphic representation of those data. You would much rather have the lung in the blue, which was exposed to an appropriate amount of pressure, as opposed to the lung in the purple, which caused a significant reduction in FRC. Now keep in mind, a lot of these patients have compromised lungs anyway. That's why they're on the ventilator in our ICU, and that a lung recovering from a 10% reduction in FRC is going to recover much more quickly than a lung that had a 70% reduction in FRC. That said, observed in a prominent hospital, this is a two-way stopcock. So people really just don't understand these concepts. Obviously, a two-way stopcock means that the pressure is on or it's off, so this could clearly be very hazardous to your patient. These are data from the nursing literature published in Chest in 2004. And what they showed was that suctioning patients, and what they really set out to look at in the first place was they noticed that patients on pressure control ventilation did not recover from suctioning near as well as patients from volume control ventilation. Well, we're respiratory therapists. We understand that since pressure control is time cycle pressure limited ventilation and tidal volume is not guaranteed, obviously it's going to cause a bigger lung reduction. But the significant part about this is the old argument used to always be when you suction a patient, you must be causing bronchospasm, and that's what causes a decrease in compliance. What they showed here rather nicely is that in both pressure control ventilation and in volume control ventilation, there was compliance decreased by 28% in pressure control ventilation and 23% in volume control ventilation. So suctioning actually causes a decrease in lung compliance, which could only be explained by atelectasis. So suctioning causes atelectasis. This is a study that was published in Intensive and Critical Care Nursing, and what they were looking at is the evidence. So when you're out in the field, such as I am all the time, you want to make sure that you represent the nursing data as well as what was in the respiratory care data. And if everything is evidence-based, you should get the same results. And in fact, here's what they did. They looked at suctioning and what the evidence was. They talked about the consequences or the adverse effects of suctioning, which included bleeding, infection, atelectasis, hypoxemia, cardiovascular instability, elevated intracranial pressure, and may also cause lesions in the tracheal mucosa. But their data lined up very nicely with the AARC's clinical practice guidelines. What is the recommendation for catheter insertion? To the tip of the tube only. What's the recommendation for the duration of the suction procedure? No longer than 15 seconds. The AARC clinical practice guideline indicates 10 to 15 seconds. What's the recommendation on saline lavage? always a controversial issue. Should you dump saline down there to, quote, thin out those secretions prior to suctioning? And they found, just as we found, that routine installation of saline prior to endotracheal suctioning is not recommended. What's the recommendation on routine versus PRN suctioning? It's recommended that endotracheal suctioning be performed PRN only. So don't suction the patient Q1 hour just because somebody thought that was a good idea. Suction the patient only as clinically indicated. This is a study that was published in the American Journal of Respiratory and Critical Care Medicine back in 2003. And the whole title of the paper was Prevention of Endotracheal Suctioning-Induced Alveolar Derecruitment in Acute Lung Injury. So what they basically nicely did is they walked through the concepts that we all know. Repetitive alveolar collapse and reopening can be injuries to the lung. The atelectatic regions that can be exposed to shear stress generated by recruitment of collapsed alveoli causes damage to the lung. And the application of negative pressure, in this case suctioning, could further increase the shear forces resulting in lung damage. So lung injury resulting from repetitive alveolar opening and closing can affect the release of inflammatory mediators into the lung and the systemic circulation. The suspicion there is cytokine release, and we all know that when we have things going on, inflammatory things in the lung, that causes things elsewhere as well. They concluded, therefore, preventing the periodic alveolar derecruitment induced by endotracheal suctioning could be more clinically relevant than its reversal in patients with ARDS and acute lung injury. So essentially the cascade of events would be, if you deep suction, you're going to cause blunt trauma, you're going to cause injury of tissue tear. That bleeding is also possible since the lung is highly vascular. Tearing of the lung tissue, like the tearing of any tissue, causes an inflammatory response. And we know that when the body starts inflammatory response, that's going to cause bad things. So we want alveoli that are nice and open alveoli when we suction the patient, as opposed to collapsed alveoli. Because again, the repetitive alveolar collapse and expansion causes inflammation, causes shear force stresses on the lung, etc. And that's very well documented in the literature. So all of this cascade of events results in biotrauma. So if the epithelium becomes disrupted, the cell membrane becomes inflamed and biotrauma can occur. So biotrauma refers to both a cellular and inflammatory mediator-based lung injury that follows mechanical lung injury. And then cytokines are released, and cytokines are kind of the 911s of the lung, and they run around in the lung and migrate into the systemic system and cause problems. So on the left, we've got an alveoli and alveolar macrophage that's intact, and type 2 pneumocytes are intact. We have a nice alveolar capillary membrane. On the right is an inflamed alveolus. And when we get an inflamed alveolus, we start getting leukotrienes, we start getting substances that are released in the lung. The alveolar macrophage starts having an inflammatory response, causes a widening of the alveolar capillary membrane. We get things like white blood cells that migrate from the bloodstream into the lung, and we get this whole inflammatory response that causes problems not only in the lung, but in other organ systems. So again, the cascade of events would be the atelect trauma, the biotrauma, tissue injury second toward the inflammatory mediators, and we get a multi-system organ failure. If you think about it, patients in ARDS or acute lung injury don't die of ARDS or acute lung injury. It's usually a kidney failure or a liver failure or some other organ system failure. But that very well may have been instigated from inflammatory responses in the lung. How big of an issue is the suctioning lack of knowledge? This is a critical care clinician survey that was done actually at the American Association of Critical Care Nurses meeting. And even after some education was done showing them the correct way to set a vacuum regulator, only half of them actually had the awareness to get it right in terms of how they need to occlude the tubing to actually set the vacuum regulator. So let's shift gears and talk about subglottic secretion removal. A lot of hospitals have tried the subglottic secretion removal, the high-low EVACs, those types of endotracheal tubes. And a lot of them have been unsuccessful in making them effective in their hospitals. So we'll talk about the consensus and evidence. They are recommended by the infection control community. The CDC recognizes that there is a substantial amount of literature showing that these devices help to prevent ventilator-associated pneumonia. When they work very well. They are very expensive, so that's one of the key things that you have to make the decision on is when I intubate a patient, who do I put these more expensive trilumen tubes down as opposed to a standard bilumen tube with a cuff and a standard port. So that's a key decision. And then once the patient is on the ventilator, with what point in time do I decide, am I going to re-intubate the patient with one of these tubes if I didn't have one of these tubes in it? So there's some innovations that are going on that we may in the future have some solutions to some of these issues, but right now it's a very difficult decision. There are reported problems with the lumen that you use to evacuate out the subglottic secretions being occluded, and I'll show you some literature that says that is actually with tissue mucosa, not mucus, tissue. So we're biopsying those patients. Vacuum regulators set too high contribute to the problems with subglottic secretion removal as well. So again, you need to occlude to set those vacuum regulators just like you would an endotracheal tube or a nasogastric tube. And essentially the pressures are 20 millimeters of mercury, continuous suctioning. There's a migration towards intermittent suctioning, and I would recommend 120 millimeters of mercury or less for intermittent suctioning. There's two studies here. The first talks about failure to aspirate subglottic secretions with the EVAC endotracheal tube. And what they showed was of the number of tubes of the patients that they studied, 48% of the time the tubing was occluded. Of the time that tubing was occluded to evacuate those subglottic secretions, 43% of the time it was attributed to blockage of the subglottic port by suctioning tracheal mucosa. So in other words, they were evacuating tracheal tissue up into that port. The second study shows a tracheoesophageal fistula was formed due to the subglottic secretion tube to the CAS tube. So clearly an impact of both of these issues would be how much pressure you're using to power that port for those tubes. So clearly you need to occlude the set, and clearly you need to use the right pressures. This was a study that was published in Chest, and it was done by Bruce Rubin's lab at Virginia Commonwealth University. Bruce, beyond being a very prominent pediatrician, is also a biomedical engineer. And one of the things they did when they did an in vitro study regarding this issue is they had some recommendations technology-wise. It would be nice if you could stop the suction when there's no mucus flow in these subglottic secretion devices. That's actually a possibility, but it would be a microprocessor controlled type of device that would be required. So the expense might not be worth it. Sensing when there's a sudden rise in suction at the proximal port and briefly reversing the flow. So in other words, whenever the device would sense that there's pressure building up, and it actually would purge it or blow it out. And then using intermittent suctioning rather than continuous flow to clear mucus secretions. And that actually has been adopted, that recommendation. Most all the manufacturers of these subglottic secretion endotracheal tubes have adopted that. Some say use less than 150, which is the AARC clinical practice guideline for endotracheal suctioning. What Bruce Rubin's lab showed is that anytime you use more than 120 millimeters of mercury, you're going to occlude the tube every time. So again, with all suction, use the minimal amount to achieve the goal. So if you're moving good secretions at 80 millimeters of mercury or at 50 millimeters of mercury, then that's the amount of pressure that you should use. There also may be an opportunity to change the design of the suction port to retain effective suction. And that actually has been done by specifically the Mallinckrodt people. Now, one thing I want to raise here is the tubing manufacturers recommend when you suspect that port is occluded, you should blow that out. So in other words, you should take a syringe and put positive pressure back through the tube. In those circumstances, should you put negative pressure through the tube. There's a couple of vacuum regulator manufacturers out there that have what seems like a good idea at the time, I'm sure, but it's a push to clear type of button, to where if you sense that tubing is occluded, you actually hit the button, it actually exposes that port to full wall vacuum. So that is contraindicated. I would never use such a feature. If you suspect that it's occluded, you should blow it out with a syringe per manufacturer's recommendations. The National Fire Protection Agency actually regulates all wall gases, including vacuum, and they recommend that you have a vacuum regulator and you have an overflow safety device which attaches to the vacuum regulator. Some people use these devices, some people don't. The thing that I would caution you about is if someone bypasses your canister, which was lined with a filter, and they're usually disposable. If somebody bypasses that canister and hooks the suction directly to the vacuum regulator, that stuff's going into your wall system. We have another division of our company that does the wall gas stuff, and they tell us they'll get a phone call, usually from maintenance, saying that they're running the vacuum regulators in the utility area at full capacity, and that's usually a red flag that they have some kind of debris in their wall system. So again, per NFPA recommendations, you should use a vacuum regulator, an overflow safety device, and then a filtered canister with the correct size and inside diameter tubing. So 18 inches of 1/4 inside diameter tubing from the canister to the vacuum regulator, and then no more than 72 inches of 1/4 inch connecting tubing from the canister to the patient. There's been a lot of discussion about cleaning and disinfection of vacuum regulators. The Spalding classification is the standard for sterilization used by the Centers for Disease Control and the World Health Organization. The actual document can be accessed at this website, and I would encourage one to review the actual document if questions arise. There's a lot of misinformation out there about where a vacuum regulator falls within this category of the CDC and the Spalding classifications. There is no mention of a vacuum regulator in the entire document. And moreover, vacuum regulators are downstream from the patient. They're protected by, the patient's protected by the filter in the canister. And there's never been a report of a vacuum regulator associated with a patient infection. Flow and pressure. It's widely understood that the maximum flow during suction procedures is limited by the length and the diameter of the catheter, the tubing and the resistance of the system, and due to the viscosity of the fluids being aspirated. So flow in vacuum is not very well measured. That's why we use pressure, because the flow is going to depend on the viscosity of the fluids, but more so on the inside diameter or the smallest diameter of the tubing within the system. So, you could set a vacuum regulator at 250 millimeters of mercury, and the bad news is you're going to suck a lot more air through there. So if you're not sucking secretions and you're in the lung, you're causing atelectasis. But you're not going to get any more secretions at a higher pressure. You get the flat part of the curve when you get to 150 millimeters of mercury for adults, when you get to 80 to 100 for neonatal and peds patients. This is a study that was done by Pursley, And what he was looking at is variation, although there might be different flow rates coming off the vacuum regulator by one regulator versus another, that the flow at the patient, this is through at the end, measured at the end of a 12 French suction catheter, that the flows are pretty flat. So in other words, there's slight variations, but there's no clinical significance in how much flow you're actually going to get at the patient. So higher flow at the vacuum regulator doesn't really mean anything as far as what you're going to get at the patient. And the standards for vacuum regulators, actually, there really are none in terms of flow. What there are standards for by the NFPA is the actual vacuum outlet, and you measure the flow through a vacuum outlet and look at lateral drops in pressure and flow without a vacuum regulator in there. So how do we minimize the complications and adverse responses? One is make sure that all of your clinicians know to occlude to set the vacuum regulator. So again, you can occlude at the end of the tubing or somewhere in the tubing. My preference is to occlude right before the vacuum regulator in case there is a leak anywhere else. You're not going to down the line get a higher pressure than you desire. And then there are some technological advances now that take away the human behavioral element in terms of having to occlude that are also available on the market. If you look at this whole thing from a process improvement analysis, you assemble the equipment, you plug the regulator into a suction outlet, you occlude the tubing, and that is the step that's most often omitted. You set the vacuum pressure, and then you perform the procedure. So the highlighted step is the problem step. That's the human behavior element. Either I was told and I forget to do it, or I was never told to do it. And it requires education, competency, and memory. As quality improvement would state it, if the problem process step can be improved or eliminated, it's a process improvement. And so with new technology, there's an ability to assemble the equipment, plug the regulator into the suction outlet, and what's called push to set the vacuum regulator. When you actually push the regulator knob in to set the pressure, it actually occludes the vacuum system for you. So how do we minimize complications with endotracheal tube suctioning? Hypoxemia and cardiac dysrhythmias, we pre-oxygenate the patient. Make sure you understand how your ventilator works. Remember, most ventilator O2 cells are located inside the ventilator. So when I push the 100% O2 button, it may give me a 100% reading on my screen, but how long does it really take to get 100% oxygen at the patient? That might be something you might want to bench study on your ventilator so that you understand that. It could be within seconds. It could be a minute, depending on the ventilators that you're using. So pre-oxygenate the patient. Keep the duration of suctioning to a minimum, no more than 15 seconds. And again, when you quit sucking secretions, quit suctioning. And also use the minimal amount of pressure possible to achieve your goal. To avoid atelectasis, tissue tears, and bleeding, use shallow suctioning techniques. Use the correct maximum pressure. You've read a lot about lung recruitment maneuvers, and there's various automated lung recruitment maneuvers now being put into microprocessors on ventilators. So that's something that's a tool. That's a growing area of data to say, should we pre-oxygenate the patient and do a lung recruitment maneuver prior to suctioning as opposed to just after suctioning? So the literature will pan out and tell us where to go there. Suctioning overall, you want to avoid tissue tears, bleeding, infection, and tissue injury. You want to use a proper technique to set the suction pressure. You want to use the correct suctioning pressure, and again, the minimal amount of pressure to achieve the goal that you're trying to do. Use the correct catheter size. We did not talk about that, but generally the suction catheter should not be larger than 1/2 the diameter of the endotracheal tube, with the exception of pediatric and neonatal patients. and then make sure you use careful adherence to aseptic technique. In summary, suction is very powerful. There's really no other way to regulate it down versus using a vacuum regulator in the wall right now. In the future, we may have more automated systems that will make it easier for safety. But right now, we have to supply the entire campus of your hospital. And the only way to do that is to have that vacuum regulator system be 600 millimeters of mercury plus, where our working pressure down at the patient is usually less than 150 millimeters of mercury. Suction procedures have been overlooked as a potential cause of lung injury until recently. The folks at Rush University started taking a look at this in an animal model a couple of years ago. There's strong suspicion that inadvertent oversuctioning causes cytokine release. That has not been documented yet because of lack of an animal lab that could ventilate animals for more than 5 or 6 days. Clinicians are largely undereducated on suction basics. As I travel the country, I get in front of both respiratory care and nursing students. I had one group, bad news, it was in Hawaii. I had one group that had a bunch of nurses and a bunch of respiratory students, and both groups had not been taught how to properly set a vacuum regulator nor what the proper pressure should be. So know the pressures for the various procedures, know how to set the pressures correctly, know the new clinical practice guidelines, and integrate those as part of your policy and procedures. As critical care clinicians, we play an effective role in patient safety, integrating our expertise in suctioning and employing lung protective strategies to reduce sepsis and multi-system organ failure. So it doesn't matter if you're the admitting person, admitting the patient to the hospital, or if you're the transporter taking them to their room, or if you're the respiratory therapist and the nurse and other caregivers that are required to suction the patient to evacuate secretions, we can all make a difference. And these days, that difference might be integral to our hospital's survival. So patient safety in all things we do is going to continue to be a major, major emphasis. So with that, I will stop, and now Shauna, you can open it for questions.
Thank you so much, Bill. Boy, our chat room has just exploded with questions. This is fantastic. So I'm going to go back up to the beginning of your presentation with a few questions. One of the questions that came through is, what if you have one of those very difficult patients where you're using the appropriate amount of suctioning, and we're at 120, 130, we end up at 150, and we're still not able to suction appropriately for that patient? What do you do when a suction of 150 is insufficient for that patient's needs?
Well, there's got to be a reason that when you get to 150, you're still not evacuating secretions. And first of all, I'm glad that they didn't go beyond 150, because going beyond 150 is going to get you no more secretions. So the reason that the secretions weren't mobile is probably because they were so thick. So humidification is an issue, hydration is an issue. One could not argue, and I wouldn't, that with an N of 1, where people say, I had stuff so thick, I'm going to put down some saline to try to just get something moving. I think I could not argue with that. However, it's not routinely recommended that you do that.
I have a quick question for the audience as we move into this question and answer session. When I was working clinically, granted it's a few years ago, we were talking with our pulmonary group, who was unfortunately doing quite a few bronchoscopies on our patients and seeing a lot of that trauma with suctioning, and that became a big patient safety issue in our particular hospital at that time. Is, for the participants, give me a green check mark for yes or a red check mark or a red X for no. How many facilities out there are making suctioning hazards, a priority. So green check mark for yes, red X for no. Okay, I'll give that a second to populate a little bit. And while we're waiting for that, this is another question, Bill, related to the vacuum. One of the participants states that the inline suction catheter companies recommend a 20% higher vacuum than regular sterile catheters, the non-inline suction catheters. They also recommend to count to 2 prior to pulling out of the patient's airway. Do these recommendations from the AARC take that 20% recommendation into account?
I believe that they do, but not being an author of those recommendations, I couldn't state that for sure.
Okay. Before the end of the webcast, I'll put a link to that CPG in the chat box so that we can all go back there and take a peek at that. So switching gears over to the ventilators measuring cuff pressures and such. The first question is, we talk about the ventilators measuring compliance. With the technology that we use in mechanical ventilators today, first of all, can we believe that measurement that the ventilator makes of the patient's airway lung compliance?
That's a loaded question. It depends on the ventilator and the algorithm that they use. My understanding of the literature is that all of the ventilators are doing an estimate of compliance, and that estimate is used for the ventilator's logic if you're doing something like volume control plus or PRVC, or with the Hamilton ventilator if you're doing adaptive support ventilation. It's a good enough estimate to look at relatively one patient versus the other. So in other words, I wouldn't take compliance measurements to compare patients A, B, and C, but I would use compliance measurements to say what was patient A's compliance now versus what intervention did I do, and now what is compliance of patient A.
Fantastic. Keeping our ventilator theme here, a lot of our participants are interested at this point in time what ventilators that you know of come with these cuff pressure measurements built into the machine.
The Hamilton ventilators are the only ones that I know of that have this integrated into their software. But the standalone version is called a Cuff Sentry, and it is just a device that's, if you will, it's a fancy peak valve that you to an air flow meter or an oxygen flow meter, has its own manometer, and you dial in the pressure and it maintains the pressure for you. So there's the high end, which I suspect most ventilator companies will probably start going to, and then there's the low end single patient use device, the Cuff Sentry, that's the only one that I know of out there available that really maintains a continuous pressure. I do think that cuff pressure maintenance is going to start becoming a bigger issue. We know that ventilator-associated events are a big focus. It's something that hospitals are starting to have to report now publicly, and I think subglottic secretion removal, cuff pressure maintenance, oral hygiene, all of that stuff is right in there in that ventilator-associated event bundle that we're going to have to pay attention to. I also think that once the technology is there, that the biofilm removal is going to be a big issue and a big innovation as well. I mean, there are those devices that are out there now, but those are single patient use, and I think when those become semi-reusable, I think we'll see a lot of those used to remove biofilm.
You touched on several topics that we had a lot of questions come through about. The cuff pressure regulation, for example, I know that can be a tricky situation. At what level are we inflating our cuff, and so on and so forth. Are you aware of any new studies on cuff pressure regulation that we should be considering when we're thinking about protecting the airway?
Yeah, the American Thoracic Society has guidelines that say that the cuff pressure should be maintained between 20 and 30, and that that's centimeters of water pressure, or 5 centimeters of water pressure greater than the patient's peak inspiratory pressures.
Fantastic. The other item that you had touched on was the VAE and the VAP and such. Is there sufficient evidence for using the above-the-cuff suction endotracheal tubes as a means of decreasing our VAP rates?
Yes, there is. There's actually several studies in the literature. I think one of the first and the early adopted was by Marin Khalaf at Washington University in St. Louis, here where I live, and he very clearly showed that using the high-low evac device actually decreased their ventilator-associated pneumonia rate. I don't think there's any question that when you use these tubes that your ventilator-associated events rate go down. The bigger question is that when do I put these tubes down? Do I put them down every patient that comes through my emergency room? Feasibility-wise is no, that's probably not a good idea. Do I put them in any patient that's going to the OR? Probably not. So that becomes one of the reasons people abandon this technology, is they really don't know who and when to put these tubes in because they are so much more expensive than the standard endotracheal tube. And then, you know, once the patient clearly is going to be on the ventilator for a long time, that's when you want the tube in. But then do I reintubate this patient that's now really sick and they've been on the ventilator for 72 hours? And do I take that risk of reintubation? Because we know the outcome of that is not good either. Then the other reason that people abandon this technology is because they put the tube in within 24, 48, 72 hours, the port is occluded. They can't blow it out. You can't suck it out, which again, you should not try to suck it out in the first place. But if that port is occluded, so you can't get the subclinic secretions out, then you've got a really expensive tube in the patient that is not performing its duties.
So as I look at the responses from the participants on my question about whether or not their facility is making suctioning safety a patient safety concern, I see just a few more no's than I do yeses, but that leads me into this question. We know that, for example, this year the Joint Commission's National Patient Safety Goal, a big one is alarm safety. Do we foresee a point in the future where the Joint Commission is going to look at suctioning safety as a major patient safety concern?
I think possibly they might. The National Patient Safety Foundation has looked at this. I've served as one of their corporate council members in 2011 and 2012, and they certainly are concerned about this issue. And let me just state, we're talking about endotracheal suction, we're talking about respiratory stuff here, but think about how many nasogastric tubes there are down, or oral gastric tubes there are down. Because we have the same issue, and I could have shown you some of the same slides with lesions along the stomach tract as we see, and they look much worse actually than what we see in the airway. And we know the stomach is dirty, so it's really nursing and your intensive care units that ought to be paying a lot of attention to this issue, because if they're using too much pressure for nasogastric tubes, that potentially could cause a lot more infection and harm and death than we do with endotracheal tubes.
Do you want to touch on the controversial use of saline as a lavaging agent for suctioning the airway?
Sure. Let me quote my good mentor and friend Bruce Rubin, who we actually made our nurses study this when I was at St. Louis University campus at Cardinal Glennon Children's Hospital with him. And he explained it very simply. He says, okay, you've got bacteria-laden biofilm in the endotracheal tube, and what you're doing is you're putting saline down there, so you're washing that biofilm down into the lower airway. And then in those days, we didn't use closed suction catheters, so we would, quote, bag the patient, or there is still some notion that, you know, we're still ventilating the patient, or we may give patients some extra breaths. Now we're aerosolizing those bacteria down into the lower airways. So again, you can't argue with an N of 1 If there's cases, and I always, as I lecture throughout the country, I get somebody who raises their hand and said, well, we did this on a patient and it worked. And I say, I can't argue with that, but it's not routinely recommended. I think the solution that we're working on, not me personally, but the industry, is there should be some kind of substance we can use to help make those secretions less adhesive and less viscous so that we can suction them out of the patient.
Thank you very much. One last question. I wish I could ask all of them, but we just don't have enough time to ask all these awesome questions. Pre-oxygenation and the use of increased PEEP pre and post suctioning. Benefits or patient-by-patient case? What do you think?
I actually am not the expert on that. I would refer you to the literature, and I believe there's even some data in Respiratory Care Journal about that. So what you'd want to look at is lung recruitment maneuvers. And you can search on lung recruitment maneuvers and suctioning. There are a fair bit of it to say pro, fair bit to say con. The last one I read said that clearly there's physiologic advantages to doing it, but outcomes no different.
Thank you very much, Bill. Again, this has been a fantastic presentation, and it's a great way for us to really internalize this Patient Safety Awareness Week within the role of the respiratory therapist and things that we do on a regular basis. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRC eContact Hour. If you are watching this program as an archive, this concludes our presentation.